Our next topic for today is psoriasis. Psoriasis is a common chronic and recurrent inflammatory skin disease. It is characterized by circumscribed erythematous, dry scaling plaques of various sizes, usually covered by thick, silvery white lamellar scales, as can be seen here on the scalp of this patient on the left and on the forearm of this patient on the right. The lesions in psoriasis are symmetrically distributed, and the symptoms that a patient might be complaining of would be itching or burning in the inflamed red lesions. The mean age of onset for psoriasis in a patient would be about 27 years of age. However, we have seen cases of psoriasis appearing in children as young as neonates and in the elderly as well. There is no sexual predominance to this disease. Males and females will equally get psoriasis. However, psoriasis is known to be a hereditary skin disease with a multifactorial inheritance. In fact, if one parent has psoriasis, then there's an 8% chance that some of their children will develop it. And if both parents have psoriasis, then there is even a higher 41% chance that some of their children might develop psoriasis as well. Psoriasis is a disease that is characterized by exacerbations and remissions, and some of the trigger factors that might exacerbate this disease include infections, stress, and the intake of some drugs. Smokers and alcoholic beverage drinkers also tend to have more recurrences of this disease, as these seem to be triggering factors for it as well. As is physical trauma to the skin, also known as Koebner phenomenon, which we can see here as these linear psoriatic papules on the skin of a patient that looks like he or she has scratched it. Psoriasis is known as a hyperproliferative disorder, and we can see it in this histopathologic specimen as a very thick stratum corneum. In fact, in psoriasis, there is a shortening of the keratinocyte cell cycle, leading to 28 times the normal production of epidermal cells. Inflammation also plays a role in the pathogenesis of psoriasis in the form of activation of T cells and cytokines. The classic lesion of psoriasis is a sharply marginated erythematous papule or plaque that is topped by the very distinctive colored silvery white thick scale. Lesions of psoriasis also exhibit what is known as the Auspitz sign, wherein there is the appearance of blood droplets when the scale is removed from the top of a psoriatic papule or plaque. Sites of predilection, or the areas of the skin where we expect to see lesions of psoriasis, are as follows. We see psoriatic lesions on the scalp, on the elbows, in the gluteal cleft, in the ears, in the umbilicus, on nails, in the genitalia, as well as on the knees and the toenails. There are many different types of psoriasis, and we will be discussing two of the more common ones here. The first is an eruptive or inflammatory type known as guttate psoriasis. Guttate psoriasis refers to the sudden appearance of numerous minute papules on a widespread area of the skin. And these lesions can be seen with or without scaling, but they do look like raindrops on the skin of the patient, hence the name guttate psoriasis. These types of lesions have a greater tendency for spontaneous resolution. To the chronic stable or plaque type of psoriasis, which is also a very common presentation of this disease. Here we see sharply marginated, dull red plaques with the very thick, adherent silvery white scales, and we can see them on many different parts of the patient's body, and they can be present on the patient's skin for months to up to years on end. Fingernails and toenails are frequently involved in the disease. In fact, 1 in every 4 patients with psoriasis will have finger and toenail involvement. And the involvement can be seen as subungual hyperkeratosis or thickening of the nail plate, onycholysis or separation of the nail plate from the nail bed, oil spots, which are yellowish spots on the nails as can be seen here, as well as nail pits. Now, any skin eruption that presents with papules and scaling, what we call papulosquamous dermatosis, can be considered a differential diagnosis for psoriasis. But here we will be discussing 2 of the more common ones, namely Seborrheic Dermatitis and Pityriasis Rosea. Seborrheic dermatitis is a very common chronic inflammatory dermatosis. In fact, it occurs in 2 to 5% of the general population, and we commonly know it as dandruff. It is more commonly seen among males than among females. Seborrheic dermatitis may first appear within the first few months of life and peak again in the elderly. However, majority of patients who have seborrheic dermatitis fall between the ages of 20 and 50. There is an increased incidence of this in HIV-infected individuals and in those who suffer from Parkinson's disease or other chronic diseases as well. Seborrheic dermatitis can be seen on the scalp as yellowish, greasy, crusted lesions on an infant, which we also know as cradle cap. It can also be seen as white, flaky, pruritic scales on the scalp, as can be seen on this patient on the right. Other parts of the skin can also have seborrheic dermatitis, and they can be seen here as erythematous papules and patches with light scaling on the face, especially the nasolabial creases and the eyebrows, in and around the ears, the pre- and post-auricular area and the earlobes, as well as in the trunk and body folds. Seborrheic dermatitis can be easily differentiated from psoriasis based on the degree of scaling and erythema. On the face of this patient, you can see that the lesions of seborrheic dermatitis are only slightly erythematous and topped by scant, loose scaling, as opposed to the similar lesions on the face of a patient with psoriasis, where you can see that the plaques are much more erythematous, much more well-defined, and topped by much thicker silvery white scales. On the scalp, you can see the same difference. Seborrheic dermatitis on the scalp presents as slightly erythematous plaques with loose, scant scaling, as opposed to psoriasis, which presents with this very thick, distinctively silvery white scaling. The etiology of seborrheic dermatitis is said to be complex and is still essentially unknown. A yeast called Pityrosporum ovale seems to play a role in its etiology, as well as possibly stress and the upregulation of interferon and interleukins. However, these factors are still being studied up to the present. For scalp seborrheic dermatitis, over-the-counter shampoos containing ketoconazole, cyclopyroxalamine, zinc pyrithione, and tar seem to be beneficial. For the face, the trunk, and the body folds, application of mild topical corticosteroids or calcineurin inhibitors and the intake of oral antihistamines and anti-infectives as needed also seem to be helpful. However, in any of the cases of seborrheic dermatitis, stress management is very important in order to minimize the recurrences of the disease. Now we go to Pityriasis rosea. Now, Pityriasis rosea is a mild inflammatory exanthematous eruption. It is caused by the reactivation of human herpes virus types 6 and 7, and it is a skin eruption that can remit spontaneously in about 6 to 12 weeks. Pityriasis rosea begins with a lesion known as a mother patch or a herald patch, which is a solitary erythematous round lesion with fine scaling, often mistaken for a lesion of ringworm. This remains on the skin for a few days, alone, solitary, after which numerous salmon-colored papules and oval plaques with very fine collarette scaling start to appear all over the skin. Pityriasis rosea can easily be differentiated from psoriasis because the lesions are much less erythematous than the ones of psoriasis. They are pinkish, or what is termed salmon-colored, and the scaling also in Pityriasis rosea is very, very different from the one in psoriasis. You can see that each of these oval pinkish lesions on the skin of this patient have very fine, almost wrinkly onion skin-like paper scaling on top, as opposed to the ones here in this patient on the right who has psoriasis, where you can see that each and every one of these guttate lesions are very erythematous and very thick, topped by thick, adherent, silvery white scales. With regard to treatment, if there are only a few lesions of psoriasis, or if the eruption is localized, then topical treatments in the form of topical corticosteroids, topical anthralin, vitamin D analogs like calcipotriol, and tazarotene will suffice. If the lesions, though, are more widespread and more generalized, then more systemic or widespread forms of treatment are needed, such as phototherapy, oral retinoids, systemic methotrexate, IV cyclosporin, and monoclonal antibodies and fusion proteins are the treatments that are needed. Psoriasis has a very unpredictable course. Some patients may experience a localized form of the disease, localized to only the scalp or certain parts of their skin for many years. But some patients may have a very sudden and widespread onset of this disease. Suffice it to say that psoriasis, for every patient who has it, tends to be quite recurrent and persistent. In fact, once diagnosed, a patient who is diagnosed with psoriasis will have psoriasis for life. But with the proper treatment, proper management, and the proper education of the patient, even this persistent disease can be controlled.